Good morning, everyone. Thank you very much for welcoming me in this very pleasant and useful forum for all of us. And thank you very much for the organizers, Professor Djokovic, Professor Stojanovic. Thank you very much, Professor Vera, Professor Val, for your leadership. And thank you very much. I'm more than pleased to be here with you to present the update on the new antiphospholipid syndrome classification criteria that we are developing right now. Do you see my slides?
Yes, everything is fine.
Perfect.
Everything fine, Stephane.
Perfect. So this work in development is a teamwork, and you will see that a lot of people are involved in this huge work that we began in 2015. So it's almost 6 years of hard work, and I hope that it will be available next year. So I'm the co-PI for Europe, and all of you know that Dore Kirkan is the co-PI from the USA on behalf of the American College of Rheumatology and EULAR. I will just want to thanks very deeply Ray Naden for his help and all his insights for the development of this criteria. And unfortunately, he died last year, so we lost a piece of our classification criteria with him, and I would like to devote this work to him. Here are my disclosures. So all of us are convinced that APS is more than thrombosis or obstetrical morbidity, and of course, Graham Hughes elegantly described that there are multiple manifestations that can be associated with APS. We can have asymptomatic arterial venous microvascular involvement, catastrophic antiphospholipid syndrome, of course, described by Ricard Cervera. And our current classification criteria are based on thrombosis and pregnancy morbidity. But since a couple of years and decades, evidence is increasing. And we know now that some other manifestations are clearly significantly associated with the presence of antiphospholipid antibodies, either based on epidemiological studies, but also based on bench results which are very important to find the clue of the disease. So here you can see that based on meta-analysis, heart valve disease, and I know that Professor Djokovic is very interested, Professor Stojanovic also, on the heart valve involvement and heart involvement overall. And we know now that there is a clear epidemiological link between those two manifestations, heart valve disease and antiphospholipid antibodies. And the limitation of the current APS classification is that we are representing heterogeneous manifestation, and that those non-criteria manifestations are not involved in the PAST and Sydney Sapporo criteria. The stratification is based on lupus diagnosis or other thrombosis risk factor. This is not done so far. The definition of pregnancy morbidity can be always a challenge, and the definition of a positive APL test also. And we do not take into account the risk associated with different assays, meaning lupus anticoagulant versus anticardiolipid antibodies and so on. So we know that there is a step, and there can be some improvement for improving the current classification criteria. And we also know that we have significant advancements in the methodology of classification criteria. And if I can resume these advancements in one slide, I would like to present that those new classification criteria for rheumatic diseases on behalf of the ACR and EULAR involves 4 stages. Phase 1 is a generation of items, meaning that you want to identify all manifestations that can be linked with antiphospholipid antibodies. Second phase, you reduce these items because, of course, you cannot take all the manifestation in the classification criteria because it would be impossible to manage, but you have to reduce. Phase 3, you reduce further, and then you attribute a weight for each criteria in order to see if a manifestation is more associated with the APS than another one. And then you identify a threshold. Above the threshold, the patient can be classified as APS. And then phase 4 is the refinement and validation on a derivation and validation cohorts. Everything is based on expert consensus and is also based on data, and it's data-driven methodology. You already identify some ACR-EULAR classification criteria, for instance, the one for systemic sclerosis published in 2013, or the classification criteria for gout in 2015. And of course, obviously, the one for lupus patients, systemic lupus erythematosus. And it works like that. You have different domains. These domains involve one or several clinical manifestation or laboratory manifestation. And each time you identify one manifestation, you can score this manifestation, and the higher number of points, the higher likelihood of having lupus erythematosus. So, and if you are above the threshold, then you can classify your patient as having lupus erythematosus. So it's exactly the same methodology that we are following for the APS classification criteria. And I would like just to clarify something which is very important, that our classification criteria are not devoted to diagnosis. And there is a clear definition, differences between diagnosis and classification criteria. Classification criteria, the goal is to define a homogeneous group of patients that can be involved in clinical studies for research only. There is no impact for billing or reimbursement. There is no impact on treatment or for treatment. It's devoted to research. And unfortunately, all ACR-EULAR projects for classification criteria supports classification criteria, but not diagnosis criteria. So we are developing those classification criteria only for research. On the other hand, a diagnosis criteria, you can include all the patients you can imagine, even with unusual presentations, and you can have heterogeneous group of patients, but it's not for research. It can be for research, but it's the goal of classification criteria is to have homogeneous groups. So here are the efforts to develop the new APS classification criteria. We began in 2015 with the creation of the APS task force during the International Congress in Cyprus. And then a grant steering committee. We had preliminary data developments and a survey to be sure that we were going in the right direction, and the classification criteria was useful for the APS community. We were granted in 2017. Here is the core planning group involving Derek Khan, Meda Berbaya, Karen Constant-Bonder. She's in Boston, and she's helping us a lot because she has experience in the previous lupus classification criteria. And Ray Naden, unfortunately, now his wife, Alison Hendry, is helping us for the methodological aspects of the classification criteria development. We have administrative research support and also an ACR-EULAR liaison, who is the Professor Ronald van Vollenhoven. There is a steering committee, and I would like to thank all the people involved in the steering committee, of course. And now I would like to go over all the different phrases in order to describe what we have done so far. So the timeline is beginning in 2015. We performed several meta-analyses, and there are also some meta-analyses that are almost finished to identify the epidemiologic link and the association between antiphospholipid antibody and some manifestation to increase the evidence. We generated items in 2015. here is the table including all the different manifestations that were included in this phase 1. Look, you can have, we were able to identify 25 different clinical manifestations among the neurologic domain, which is huge, including what we have discussed a couple of minutes ago: migraine, white matter lesions, stroke, and so on. And the question was asked to the expert was to describe all features that in your experience can occur as part of APL-APS spectrum. And the second question was to describe all features or concomitant diseases that, if present, would make you question the diagnosis of APS. For instance, if you have a cancer and thrombosis, do we think that the thrombosis is due to cancer or to APS? So it's a way to identify confounders, which is very important. Then in phase 2, from April 2017 to April 2019, we reduced these items using Likert scales, meta-analysis, 3-round Delphi exercise, and nominal group techniques and teleconferences between experts in order to identify the clinical manifestation to a more manageable number of clinical manifestations. We perform surveys, and based on the 261 phase 1 items, we reduced to a more manageable numbers. We ask experts to rate each item in order to see if it was clearly highly likely associated with APS or not, with the -5 to 5 +5 Likert scale. And then we were able to identify very specific, the most specific items associated with APS. We reduced these items until 27 items, and I would like to thank all phase 1 and phase 2 investigators and also patient representatives that were involved in our classification criteria development. Then we obtained 27 items based on several domains, as you can see: domain 1 for lab test, domain 2, 3, 4, 5, 6 for clinical manifestations. And you can also identify that some of the non-criteria manifestations are now involved in those domains. And all these different steps from phase 1 item generation to the reduced items until 27 items, these efforts were published in Arthritis Care and Research in last November. So it's available, and you can, of course, read it to see all the different details of these different steps. And now I would like to show you the recent advances regarding phase 3 and phase 4. Phase 3 was, the goal was to reduce these items, to give a weight to each criterion and to identify a threshold. And we began in June 2019 with the preparation of case vignettes. It's not, it's a case vignettes based on real life scenarios. And we asked 17 international physicians specializing in APS. We identify those case vignettes and we ask them to rate those cases using a Likert scale, as usual, from -3 to +3. And then we compared, I will show you the case vignettes and the comparison between two groups, the groups with highly likely APS and the equivocal or unlikely APS cases. And then we were able to evaluate and to identify a risk ratio that correspond to the association between highly likely compared to equivocal unlikely APS cases. So in phase 3, we were able to include those 314 case vignettes, and those case vignettes are described here and compared according to the likelihood of APS. You can see that lupus anticoagulant is clearly associated with highly likely APS or different other manifestations, and the risk ratio column is on your right-hand side. This was presented during the ACR 2020. And the steps that we've performed so far was to identify a weight for each criterion and to identify a threshold. And we did that using a data-driven method, which is called 10,000 mind, the 1000 mind software. This 1000 mind software works like this. You create case vignettes, you rank the case, you score the case, and then you identify a threshold and a weight using comparison between cases. For instance, you have a young lady with estrogen pill with DVT with thrombocytopenia, and the other young lady with DVT, estrogen pill, but not thrombocytopenia, but livedo. Which of the two cases is the most associated with APS, the one with livedo or the one with thrombocytopenia? And using this comparison based on the assessment by experts, the 1000 mind software was able to identify a weight for each criterion and to identify a threshold for APS classification. And now we are beginning the phase 4, which correspond to the refinement and validation of this classification criteria with all the different weights and the thresholds. And we are beginning the prospective validation in the validation cohorts. I would like to thank all phase 3 case collectors, but also all phase 4 case collectors with now a cohort of more than 800 clinical vignettes to validate our classification criteria. So it's clearly a moving research program. We are going forward, and I really I would like to acknowledge all the different collaborators that made this possible, and I hope that we will be able to present the results of this classification criteria next year. Thank you very much.